教授都識聽廣東話。咁另外盛教授咧就係我哋個香港中文大學醫學院嘅外科教授，但係佢個專科咧就係耳鼻喉專科，咁亦都喺呢個耳蝸殖嘅方面咧係一個非常有專長。咁所以咧今日佢講個演講題目咧就係耳蝸植入和華南鼻咽癌。So our next speaker is Professor Andrew Van Hasselt. Andrew is our professor of surgery at the Chinese University of Hong Kong, and his specialty is ear, nose, and throat surgery. And he's also an internationally renowned expert in cochlear implantation. And he's going to talk on one of his hobby horse, cochlear implantation nasopharyngeal carcinoma in southern China. And Andrew.
Mr. Patrick Kuhn, Dean Fock, Professor Joseph Song, Professor K.S. Wu, ladies and gentlemen, it really is a great pleasure to be here, and I would like to acknowledge the Dr. Stanley Ho Medical Development Foundation for giving us the possibility, facilitating us to be here to share with you this afternoon. Thank you for the kind introduction, Dean Fock. I am going to call on you, if you don't mind, at some stage in the talk to do a little bit of translation for me in case I get it wrong, because it's so easy in Cantonese to get it wrong, which is what I would like to illustrate. I'm going to start with nasopharyngeal cancer, and these two particular topics, nasopharyngeal cancer and cochlear implantation and profound deafness, are something that are very, very close to the community and very close to the medical profession as well. It doesn't really matter what field you work in. I'm going to start with a little bit of background on nasopharyngeal cancer, talk something about the clinical features, the diagnosis, primary treatment, some failures in the treatment, and then some morbidity. Now this map just serves to illustrate how the high incidence of the disease focuses very much on our area in Macau, in Hong Kong, in southern China. This is really where the high incidence of nasopharyngeal cancer lies, and we are aware that in the fisher folk, they exhibit double the incidence of their land-based siblings, implicating something in the diet that predisposes them to the high incidence of this disease, presumably the nitrites and the nitrates in the preserved foods that they eat. The other interesting aspect is the almost exclusive association with Epstein-Barr virus, 100% association with the Epstein-Barr virus and nasopharyngeal cancer, as opposed to other head and neck cancers. It does not apply to this extent to other head and neck cancers. This geographic incidence is really dramatic, and when you look at the population of Guangdong province at 66 million, this translates into excess of 13,000 cases, new cases, on an annual basis in this one province alone. You can imagine the economic impact on this. Now, southern Chinese Cantonese are entrepreneurial and adventurous, and they go all over the world, and you can see that they do carry the high incidence with them wherever they go. This implicates a genetic predisposition, and the genetics of the disease are busy being worked out and worked on in current times. The genetic factors in the Epstein-Barr virus association do open the distinct possibility for screening for this disease in an attempt to detect the disease early. It also opens the possibility to monitor the success of treatment and to monitor individual patients following treatment. It is interesting to note that the disease rises in incidence at an early age, much earlier than other common cancers such as colorectal cancer and cancer of the bronchus, which rise in incidence as the patient gets older, but the incidence of nasopharyngeal cancer does tend to drop and have a peak incidence in the age groups of between 40 and 55. The socioeconomic impact is quite markedly illustrated by looking at the incidence of common cancers in Hong Kong, noting that in adults below the age of 50 years, nasopharyngeal cancer is almost twice as common as any other cancer in these adults. And because it's more common in males, it does impact on the breadwinners in the society. Not that it's only males that work. Certainly females have a very high incidence of working here. Unfortunately, despite the awareness of the medical profession as well as the community, the disease is diagnosed at an early stage in a very small percentage of cases. And this remains one of the challenges of dealing with this disease in the community. So the main presenting complaints that bring the patient to see their general practitioner, family practitioner, or the specialist indeed, is the presence of a neck mass. They note a neck mass, nasal symptoms, blood-stained nasal discharge, and then oral symptoms, unilateral deafness or tinnitus in about 1/5 of the patients, bring them to see their family doctor. However, at the time of diagnosis, in fact, 3/4 already do have metastases in the neck. 1/3 have effusions in their ears, and a very small percentage have a normally appearing nasopharynx. Clinical features, as we mentioned, are the neck mass, and the way the specialist does monitor this and look and diagnose it is by using either rigid lenses through the nose or flexible lenses directly through the nose, looking at the nasopharynx, getting a very clear view of the nasopharynx. Here you see the back of the nasal septum, the floor of the nose, the eustachian cushion, and then just close to the eustachian cushion is where the disease would arise. Alternatively, an angled endoscope placed transorally and looking up into the nasopharynx provides a panoramic view so that one could detect any slight asymmetry or abnormality in the nasopharynx. And should one note it, such as in this particular case, which there's an ulcer and a little mass, small mass, in the lateral recess fossa of Rosenmuller, then this can be accurately biopsied. It needs to be biopsied because we would never go ahead and treat a patient on an X-ray finding or on any other finding. It needs to have a tissue diagnosis. So if we see any abnormality, we would go ahead and biopsy straight away. And this slide serves to remind me to mention that we take a biopsy of a large piece of tissue because these tumors are often covered in slough, and if one uses small biopsy forceps, then one does not get necessarily an accurate representative tissue from the nasopharynx. And here you see illustrated that a biopsy is being taken under direct visualization, and this can be a very accurate biopsy. As shown in the other picture, you can see a small raised mass here with an ulcer and the biopsy site just on the edge of that ulcer. Interestingly, this particular case turned out to be tuberculosis of the nasopharynx. So it would have been a disaster if this was treated for nasopharyngeal cancer without a tissue diagnosis. We do see advanced disease, and we stage these cases using scans, and you see in this MRI scan extensive skull base erosion going into the cavernous sinus that is obviously causing a sixth nerve palsy on the right side of this particular patient. It's quite interesting to note that in some of these patients that have extensive skull base erosion, there are no neck nodes at all. On the other hand, when there's extensive lymph node enlargement in the neck, there is absolutely no skull base erosion. And this is a particular strange facet of behavior of this disease, that it either seems to go up through the skull base, causing cranial nerve palsies, or go down into the neck, causing lymphadenopathy. And we don't have an explanation thus far for this feature. Now, the early stages of the disease are treated with radiation therapy, and the latter stages of the disease with radiation therapy and concurrent chemotherapy. There have been new developments in radiation therapy. Radiation therapy is the gold standard for treatment, and because this endemic disease is almost entirely undifferentiated or non-keratinizing squamous carcinoma, it is extremely radiosensitive. And so the developments in radiotherapy have been to focus the effect of the radiation to conform more with the volume that the tumor occupies. And so this takes the form of 3D radiation therapy or intensity modulated radiotherapy. And this illustrates the conventional radiotherapy on the left-hand side with the intensity modulated radiotherapy that has 7 beams from different directions that can conform better with the volume of the tumor. And the early clinical outcome does show that there seem to be reduced local recurrence, in other words, more effective treatment, and also there's reduced side effects. However, when the tumor is exposed to radiation, not only does it melt, and you see the effect of the radiation here, this tumor has melted away completely, this is the same patient, but it does also affect tissue that is normal tissue. And with these 7 beams, tissues in the nose and sinuses and in the pharynx, as well as in the ear, do get exposed to radiation, causing a certain amount of morbidity. And the orientation of treatment is in order to not only make the treatment more effective, but to reduce the side effects. And we are being somewhat successful. I will come back to this in a little while. Now, the concurrent chemotherapy is standard for advanced stage nasopharyngeal cancer, and the cytotoxic agents that are used are cisplatin and 5-fluorouracil. And the outcome of more than 2,500 patients treated at the end of the last century, which is not that long ago, but it sounds like a long time ago, are actually quite encouraging. However, we still do get some local failures. And when we have a local failure in the nasopharynx, we need to ask ourselves, what is the best treatment option? Is it to re-irradiate? And you see that some of these patients have had up to 74 gray. Do we re-irradiate them, or do we perform a surgical resection? And it seems that there is evidence to show, and this evidence comes from our own studies, that surgery does offer benefit to those patients who are potentially salvageable with local failures. And with modern imaging techniques, we are able to see quite clearly whether they are salvageable. And here you see that this tumor is abutting against the internal carotid artery, and this is not resectable. It's far too close to the internal carotid artery. But when we can, and we have also technology in the operating theatre to help us with image guidance systems, and this serves to give us a view beyond the surgical field, so we can see beyond where we are actually operating, which helps us to accurately resect the tumor. So when we have this technology, we do have several different approaches. We can go through the palate, through the mandible and the palate, through the nose, through a midfacial degloving approach, or through the maxilla, depending upon the situation of the recurrence in the nasopharynx. And here we have a patient that we've chosen to go through the maxilla. You can see the wound, the incision mark that we have marked out, and through the palate we have to go, and you can see the employment of the image guidance system so that we can see exactly where we are, because we have vital structures just beyond the field of view that we need to take great care of. And here you see the maxilla has been swung out. This is the maxillary swing procedure, giving us a good view into the nasopharynx. And in fact, the post-operative wounds heal particularly well, and you can see in this patient that there really is not much deformity on his face, or in fact on his palate. If we have to go into the neck to remove residual or persistent or recurrent disease, we would do neck dissection, and where we do find tumor in the neck, we would place brachytherapy tubes for radiation post-operatively. At the operative field, we have to protect the internal carotid artery, because this is very, very close to the operative field, by swinging flaps into place. Now, the ears are also exposed to radiation therapy, and you can understand, looking at these particular ears, that these patients would be quite deaf. However, if they're deaf on both sides, they would need some form of hearing aid, and it would be very difficult to fit a hearing aid in this ear canal, because there's discharge. The hearing aid would not function very well at all. And the same goes for these ear canals, where you see a radionecrosis of the ear canal, or these very thin canal skin with non-healing ulcers. And under these circumstances, what we would have to do is to place a hearing aid and integrate that into the skull bone. However, we do recall that these patients have been irradiated. So would these hearing aids integrate into the skull bone, or would the radiated bone not be conducive to osseointegrate to the titanium posts that we place there? Well, the good news is that in our experience, that there is successful osseointegration, and we have very high patient satisfaction scores for these bone-anchored hearing aids after radiotherapy. So that is one piece of good news. I'm going to go on now to cochlear implantation, and if we just look at the populations, Taiwan, Hong Kong and Macau, under the circumstances of dealing with profound or total deafness, really do have manageable populations. China's population presents an immense challenge. Now, cochlear implantation programs for the profoundly deaf were established in this region in 1995. It is extremely expensive technology, with each implant, just the implant, costing 150,000 Hong Kong dollars. It is the most expensive and most sophisticated technology to be placed in the human body. That is just for one implant. That does not count the cost of surgery, hospitalization, or anything else. Now, I want to show you a video to try to illustrate the way normal hearing works, as well as the way cochlear implantation works. I also want you to get present for a minute, thinking about what it's like to be captured in a world of total silence. Because these are the patients that we're dealing with. Total silence.
Of nucleus freedom. Let's look at how natural hearing and a cochlear implant system work. The ear consists of three sections: the outer ear, the middle ear, and the inner ear. All three sections work together to deliver sound to the brain. In normal hearing, the outer ear picks up sound which it sends in waves down the ear canal to the eardrum. These sound waves cause the eardrum to vibrate. The vibrations cause the tiny hair cells inside the cochlea to move. The hair cells absorb the movement and change it into electric impulses, which are sent to the hearing nerve fibers and to the brain. This becomes sound. A cochlear implant helps people with severe to profound sensory neural hearing loss or nerve deafness. A cochlear implant has two parts: an internal part called the cochlear implant and an external part called a speech processor. The speech processor uses two small microphones to pick up sounds. It turns those sounds into signals and sends them to a transmitter. The transmitter sends the signals through the skin to the internal implant. The internal implant converts the coded signals into electrical energy and sends them to the electrode array. This stimulates the nerve fibers in the cochlea, and the signals are recognized by the brain as sound.
So this gives you an idea of the way the cochlear implant works. Now, there are some challenges with cochlear implantation, and particularly in this region. Funding, as I mentioned, is probably the first challenge because it is extremely expensive. And in Hong Kong, we are fairly fortunate that the hospital authority provides 30 implants a year, but this is insufficient. So we as clinicians have had to go out, and we have gone to a number of different organizations, including, for example, the Hong Kong Movie Star Sports Association, Chinese Permanent Cemeteries Fund, Samaritan Fund, in order to supplement the need for cochlear implantation. This takes a lot of work, a lot of convincing of these funding organizations, because the dividend appears to be small because it's just for one or two patients such a large amount of money. Another problem is the tonal nature of the Cantonese language, where we have 6 different contrastive tones, and that, as you are all aware, that each word in Cantonese can have 6 different meanings depending on the tone that's used. And I usually use this to illustrate to Western audiences, but maybe it's a timely reminder.
Why.
What strikes me is the very different meaning to each one of these sounds. And the way it impacts on cochlear implantation is that children who have never heard before and are given a cochlear implant may learn language with an accent, and this can make it difficult for them to be understood. Now, this just goes again to illustrate the different lexical tones giving meaning. For example, when I arrived in Macau, there were several people that approached me, and although I feel I can speak some small amount of Cantonese, I didn't want to ask the gentleman whether he was a tour guide And maybe I can ask the Dean's support here. Maybe you could give us the name for a tour guide. A Chinese, how do you say tour guide?
Tour guide.
A tour guide in Cantonese. Well, if I got it wrong, I might ask whether he was a drug addict. Exactly, now I still can't hear the difference. So this has a great impact on teaching children who've never heard before and delivering the subtleties of tone changes through a cochlear implant. Well, this slide serves to illustrate that the younger that we implant these patients, the better the outcome, and the greater the dividend. And on the left-hand column, it just shows that these are patients implanted below the age of 2 years old, that they have about a 70% chance of going through mainstream schooling. That is completely normal schooling. So in other words, these children would not need any form of special education. However, if they are implanted after the age of 4, these last two columns, then they have just a very small chance of ever going through or ever being able to have the capacity to go through mainstream schooling. And they would need special schooling. This is far more expensive, and the outcome is far less optimal. We know the predictors of outcome in children are the age of implantation, as I've implied, their cognitive ability, the expertise of the entire team. It's not just a matter of implanting them. The family involvement is particularly important, and whether they have been taught in an oral mode or a total communication mode with sign language. Going to the other end of the age spectrum, the elderly are also a very important group. We did a survey on just less than 1,000 elderly people, that's beyond the age of 65 and 70, and found that a third of them have hearing worse than 40 decibels hearing level. Of those third, 1 in 5, 20%, were clinically depressed. This is natural. We are aware that hearing loss has an independent association with depressive symptoms. You can understand this because hearing loss leads to isolation, and it may cause depression, sadness, paranoia, anxiety, and decrease in social activities. It's absolutely logical to understand. And the question that we would ask is whether a cochlear implant in patients who are more deaf than 40 decibels would actually have any benefit or dividend, and what about their quality of life? Well, again, the good news is that the older adult compares very favorably in outcome with the younger counterparts. We've done a number of implants on older adults, and the outcome has been very, very encouraging. The cascade of benefits of cochlear implantation are enormous, and I'm not going to read through all of them. In contrast, the cascade of fallout of having a deaf person within the family, particularly a deaf child, it absorbs a huge amount of energy and emotion. And so cochlear implantation is a very, very worthwhile intervention for these people. Now, let's just get back to China. There are an estimated 20 million severe to profoundly deaf people in China, of whom 800,000 are children. This has been officially identified as one of the major challenges in China's effort to provide assistance to the disabled population. But this is a huge challenge. There are existing 30 cochlear implant centers in China that do 600 a year. Now, in China, there's absolutely no subsidy. It's funded entirely by the family network. And through the representation of the Disabled People's Federation, the government removed the import tax on cochlear implants, which was already a great help. The growth in cochlear implantation in China, despite lack of funding, has been a compound growth of 35%, which is really quite impressive. Interesting to note that the Shenzhen government and in Chongqing, children have been supported. Now, this is a picture of the Chang'an Memorial Hospital. And the foundation associated with this hospital, which is from the Formosa group, is quite interesting because about 5 years ago, they donated 200 units for children into southern China. Last year, This foundation donated 15,000 units of cochlear implantation at a cost of 30 million US dollars. Even in Macau, I think that's quite a lot of money. For implantation in China. This, I believe, is really very, very good news. Of course, 15,000 is not going to go a long way when we estimate that there are 20 million people that really need cochlear implants. However, it is at least a start. And what it does is that it ensures that otology centers that will implant them have a level of expertise that can provide service to the entire deaf community, not only those that need a cochlear implant. The downside of it, though, is that news spreads fast, and throughout China, the news of this donation has spread. And if you have to, in a family network, come up with 150,000 yuan, and you hear that there's a donation, you're certainly not going to come up and pay the money. So you'll wait to see if you can get one of those donated implants. So it has brought the entire cochlear implant program in China to a complete halt until these 15,000 can start being implanted. Medical criteria for implantation are constantly evolving, and as we know, funding does have limits. It is up to us to provide evidence that quality-adjusted life years do show economic benefit. This is obviously more the case for children than it is for adults, and it is the obligation of the cochlear implant teams to provide feedback and data and audit back to the funding providers to show that this is a cost-effective intervention. I would also just like to acknowledge the Macau government, because the Macau government does support cochlear implantation. Coming back to the irradiated ears in those patients who have nasopharyngeal cancer, we have in our group noted that these can be successfully implanted. One just needs to take great care in drilling the irradiated bone. The facial nerve is at risk, and the hearing indeed. The balance organs are also at risk. But the speech perception results, as we have shown here in NPC cases, compares very favorably with non-NPC cases. This deafness and this challenge provides an opportunity. We should remember that deafness presents a barrier to speech development and even achieving a very basic education. It really is a massive hurdle, if you think about it, to social interaction, even within a family circle. It thus restricts social integration. Deafness holds individuals back from becoming fully functional and contributing members of society. I'd just like to show you a very short video on Ho Yin. This is a young boy who was born and never heard a sound until he had a cochlear implant. So everything that he has learned has been facilitated by the cochlear implant sound processor, translating sound into electrical impulses, stimulating his nerve ending. His brain has perceived this as speech, and his brain in turn has processed it into the ability to speak. So this is after his implantation. I'd just like to show you this.
西瓜係啦，橙係啦，檸檬啱啦嚇，仲有乜嘢啊？提子啱啦，仲有蘋果係喎，蘋果啱，仲有咩啊？可樂係水果咧。 有香蕉啊，呢個都唔係水果喎，有香蕉係啦，仲有啤梨，唔係啤梨係啦，士多啤梨係喎，個士唔係士多啤梨，哇好叻，仲有咩啊？好啊，有啲咩飲品啊？果汁係啦。
Patricia is a young lady who was married. She got nasopharyngeal cancer. Her husband left her. She was left as a single parent and as the breadwinner for the family. Radiation therapy cured her disease, but she went deaf. She had a daughter called Stephanie, and we implanted her with an osseointegrated implant. And we had a group meeting where we shared with similar patients, and Patricia was very generous in sharing and promoting the information and the intervention because she felt that she was much better. And she was asked, how did the bone-anchored hearing aid benefit you? And she said, obviously, better hearing and more effective meetings. But then one of the reporters asked her, furthermore, how did it help? My daughter did not talk to me because I could not hear, and she thought I did not care about her. Now she loves talking to me. This we find very touching and very, very rewarding aspect of our work. So I feel that the future is that period of time in which we are working towards, where our affairs prosper, our friends are true, and our happiness is assured. And this is a stand that we should take for our patients in the community that we serve. Thank you very much indeed for this opportunity to share with you.
Thank you very much, Professor Hasselt, for this very informative lecture and touching stories of the patients. 而家又可以大家隨意發問，又係可以隨意用英文或者係用廣東話發問。廣東話嘅 Hasselt Professor Hasselt 老師聽。Can I ask the first question? How much is one cochlear implant?
One cochlear implant is 150,000 Hong Kong dollars, just the implant, just the hardware. Then if you look at the cost of the surgery, cost of the hospitalization, cost of the rehabilitation, in an adult it doubles that. So it's about 300,000 Hong Kong dollars for, that is the cost associated with cochlear implantation and the rehabilitation process.
How long would each implant last? How long would it last?
Well, this is a very good question, is how long would the cochlear implant last? These cochlear implants are built to last for life, and the studies that have been done since these implants started being implanted in the late 80s, the calculations show that they should last at least 70 to 75 years. There is inbuilt technology that can be upgraded as the external part of the processor advances. So there's capacity for that implanted portion to take on that advanced technology. But what we look at very, very carefully is the reliability, because there's several companies that manufacture the implants, and it's very important to see the track record of reliability, because if an implant fails, this causes not only a lot of expense to the health provider, but an enormous amount of problem for the patient. They would have to come back into hospital, they'd have to have it explanted, they'd have to be re-implanted, and that because of fibrosis and so on inside the inner ear, the re-implantation may well, but no guarantee that it can be as good as the original one. This is very important. So far, I'm happy to say that the reliability of the implants that we've used has been exceptionally good.
And a very interesting lecture. For our patient with NPC, given the fact that they always do have a risk of recurrence, even in the earlier stage, and also the implant is so expensive, how do you wait after the radical treatment before you agreeable to consider implant?
This is another very good question. Usually, these patients do not go profoundly deaf for very quickly. They will usually be 8, 10, 15 years out, and their hearing will go down slowly, and then suddenly they'll get a vascular event or some vasculitis that causes them to become profoundly deaf, maybe in one ear and then a second ear. It's only when they're profoundly deaf in both ears that we would implant them. So usually they are cured of the nasopharyngeal cancer. Interesting question that you raised. We did implant one patient like this, and he had an excellent outcome. He was totally deaf. He had an excellent outcome. He reintegrated completely with society, particularly with his family, obviously. He then, interestingly enough, came to Macau. He suffered a stroke in Macau, came back to Hong Kong, and in hospital he was unconscious, but the family told us that the only way that they could communicate with him was through the cochlear implant. And they knew that he was hearing them because as they would communicate with him, he would squeeze their hands. So they became extremely grateful for having had that implant for their father.
I would like to ask an unpleasant question. As it is so expensive, is it reusable?
I don't think there's any question that's unpleasant. It's only with the way you choose to receive that question. I think it's a very good question. The implanted device is not reusable because obviously it needs to come in a sterile package that needs to be checked, and so that for the company to guarantee it, it cannot have been used before. However, the external portion of that hardware is certainly reusable. And this particular family came and brought all the implant hardware back to the hospital for reuse. So the external portion is reusable, but the internal portion is not reusable.
就呢種問題，如果冇呢，我哋就再次多謝Prof Hasselt。